Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful.
Hello, everyone, and welcome to another episode of Muted in Medicine podcast. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they're unprepared to face, and spreading more awareness about it. And with this podcast, we hope to discuss some of the most silenced topics in medicine that are often not out in the open. In healthcare, grief is often seen as an individual burden, something we process in silence, in between patient encounters, or after we clock out for the day. But what happens when grief isn't just personal, but collective? When an entire team, department, or hospital is grieving, whether from patient loss, systemic failures, moral injury, or just grief of injustice in this world. And what happens when that grief is ignored, dismissed, or left unspoken? Today, we are diving into the concept of organizational grief, the deep, often unacknowledged sorrow that takes root in medical institutions. We'll explore how grief affects not just individuals, but entire systems, shaping workplace culture, morale, and even patient care. More importantly, we'll discuss the role of organizational compassion, how healthcare institutions can create space for healing rather than expecting their workers to simply push through. To discuss this with me today, I have Dr. Rachel Thienprayoon. Rachel Thienprayoon is the Chief Clinical Wellness Officer and Associate Professor of Anesthesia and Pediatrics at Cincinnati Children's Hospital Medical Center. She completed Pediatrics residency and a Pediatric Hematology Oncology Fellowship at the University of Texas Southwestern in Dallas, and a fellowship in Pediatric Hospice and Palliative Care at Cincinnati Children's Hospital Medical Center. She has been a faculty member in the Palliative Care team at Cincinnati Children's since 2014. Her research focuses on measuring clinical experience of compassion within teams and organizations. She lives in Cincinnati with her husband, Paul, and their 2 girls. Rachel, welcome to the show.
Thank you for having me. Good morning.
Good morning. We ask everybody before we start the podcast, what is bringing you joy in medicine today, Rachel? It's kind of a surprise question.
No, I love this question. This is the question that we talk about in our team a lot too. I think pediatrics is just such an optimistic space because we get to take care of kids. And kids are funny and they're resilient and they're just like the best, So people who are attracted to taking care of children tend to be really fun, optimistic people and deeply caring people.
Yeah.
So whenever I am feeling a sense of despair or sadness, I need only look around me at the people I work with, and they consistently bring me joy and optimism.
Yeah. And it's interesting that you said, which is true, that kids are so resilient, but I know you're doing some of the most tough work with them in hospice and palliative care.
True. So, yeah, it's very true. Yeah. And still they're resilient.
Yeah, they are. And that's absolutely true. So I was very intrigued by the concept of organizational grief. I must say I haven't heard about it before till I kind of chatted with you offline about it.
Yeah.
And I was very interested to know more about it. So you talk about organizational grief and suffering, and what does it mean and entail, just starting from the basics?
Sure. So To back up, I talk a lot about organizational compassion and how organizations and the leaders and the teams and just the people in organizations notice when the people around them are suffering and acknowledge that suffering and then respond in a way to help. And the question was prompted to me by Matt Norvell, who's a pediatric chaplain in Baltimore at Johns Hopkins. And he said, well, what then is organizational suffering? And the first thing that came to mind was grief. Probably because I'm a palliative care doctor and probably because I work in the healthcare sector, right? I don't know that would have like risen up for someone in a more traditional workplace.
Yeah.
But that just felt real and right and salient as an answer. And so I think in hospitals, as you in your opening was really lovely. Certainly children die, patients die, and that's a source of suffering for clinicians and for teams and for units. And often patients are cared for in multiple teams. And so that loss impacts us more globally than just one specific area. But coworkers die, leaders die, and we collectively grieve those losses just as human beings who love those people and who care deeply about those people. And I think, as you pointed out in your opening too, there are collective sources of stress and distress and trauma playing out through society that can also rise to the level of like organizational grief, even if everybody in the organization isn't impacted equally or evenly by them.
Yeah.
There are enough people feeling them that it becomes an important thing to acknowledge and work through together.
Yeah. I read your article that you wrote about 2 years ago, and I picked up a line from it. I really liked it. It said, being a clinician in the United States often means working in a system that we perceive fails our patients.
Yes.
Yet if we leave, we abandon them and sacrifice a critical part of ourselves. The tension is not burnout, it's an existential struggle. So I really liked when you said that. I'm curious, what is your story? How did you get to do what you are doing over here?
Yeah, sure. I think as a medical student, you're trying to find your tribe, right? Like, who are my people?
Yeah.
Not just like, how do I want to spend my time, but like, who are my people? And my people were clearly the pediatricians. They were just collaborative and like down to earth and just like, that's my people, right? And then as a resident, you're again like, okay, but within this group of people, like, am I a duck or am I a chicken? Like, who am I? And the people I gravitated towards the most were the oncologists, because I loved the blend of like deep scientific knowledge and treatment and compassion and vulnerability. I liked sick kids, and then as I was navigating oncology, the piece that bothered me was when children were dying. It felt as though, we had applied all of this evidence and all of these resources and all of this research to save them. Science failed them. And then there was a lack of science to know what's the right next step to care for them as they die and their families, right? How do we give as much energy to this portion, which is arguably as or more vulnerable than other portions? And so that's what got me into pediatric palliative care. And so I was doing palliative care. I was doing research into, patient experiences of quality and how families defined quality in palliative care and in hospice care. And families told me that the compassion they experienced from their caregivers was so important. And they called it out as a freestanding like domain of quality in pediatric palliative care. And that they had to tell us, right? Like, clinicians and providers and research had written domains of quality in palliative care, but we left out compassion. I think we assumed that we did it and that it wasn't measurable, that it was just like innate to the care that we were providing. But parents had to tell us that's a really key piece. And so then for years, I'm just thinking about, how do we craft systems so that clinicians are able to be compassionate as the default? That they have like the emotional availability and the time to really be deeply human in the way that they're interacting with patients all the time. And that's a systems issue. That's not just, we can't rely on individuals to go above and beyond. Right. Especially in like a really highly reliable, safe healthcare system where we're like marching through all of these metrics all the time and making sure that we're doing all of that reliably every time. That they're also then like compassionate to their patients. And when I got to Cincinnati Children's as a palliative care fellow, I just appreciated that like quality and safety was the language that we speak here. And so I got into like the quality training and as I was thinking about like how do we craft systems that take care of clinicians so that we can take care of patients, ultimately, like, children's opened up this opportunity to be a wellness leader, to craft those systems in the quality space alongside the other domains of like safety and, access and patient and family experience. And so that's been how I landed where I am now.
Yeah.
But if your question was about burnout
Yeah.
and how I got burned out, I don't know if burnout is inevitable for clinicians. It feels in some ways as though the system is designed for us to become burned out at some point, just because our training teaches us, right? Like, you work all of these hours, your focus is exclusively on becoming a physician. All those other aspects of your identity are neglected in service of becoming an expert physician, right? So it's hard to be like a good daughter or granddaughter or friend. You miss the weddings, you miss the funerals, you come to work sick in service of this thing. So our personal identities and our professional identities become deeply intermingled and intertwined on purpose by design. Such that like when our professional identities are challenged, that can rise to the level of suffering. It threatens our intactness as like whole people. So when I was burned out, and I think, the burnout, I've thought a lot about how I got there. Post-COVID, I was feeling like detached from my team because I was doing more work from home. I wasn't in the office as much. I was doing more research, which was really like individually driven. I just got tired. And there were a couple of, events that sort of really just knocked my self-esteem with other people around the hospital. And it didn't feel like a slow burn. It really did feel like suddenly I was like, okay, one day and the next day I had just like fallen off a cliff. And I've been to talks where they talk about like adaptation to stress and that's kind of how we do in medicine. Like we sit up here at this like very high stress place for so long that it does feel like you crash when everything kind of falls apart. And so when I was burned out, I just did not derive any joy from work. And I would know that I had done a good job. I would know that I had like been experienced as a compassionate clinician who did the right things and said the right things. And we did a good job. But it didn't give me any sense of professional fulfillment. And I knew that I wasn't showing up for my colleagues at my best. I didn't have the emotional availability to check on them or notice how they were doing or like be available to them. And so what helped me move through it was partly writing that piece, like just really cathartically sort of dumping it like onto paper. But I was also able to use a grant that I had to pay for a coach. And my executive coach really helped me think about all of these stories I was telling myself and find a way forward. And ultimately that led to the chief wellness officer position.
Yeah. And it's interesting that you called it, as suffering, as it was sort of a suffering. I haven't heard that word used in connection with burnout, but in reality, there is so much suffering. And just talking about, I was thinking about individual grief versus organizational grief. As pediatricians, we feel deeply for our patients. So that loss is, I think, more for pediatricians, but just thinking about other things that cause some sort of organizational grief. And I'm also thinking, it's so hard because there's also polarization, when you think about different issues that are going around and some people are hurting and some people are not hurting. So you don't even have the safe space to talk about those things. So and then in other things like nursing, staffing issues, there was a time in COVID, and even now, I think when our whole nursing workforce was kind of suffering as a whole. So what do you think about some other examples around yourself? And, I just want you to elaborate on that more.
So, Eric Cassell was a physician and a bioethicist and a writer, just like a big thinker, He was writing in the 70s, 80s, 90s about the state of medicine and suffering and human suffering, the nature of suffering in medicine. And he was saying that medicine had become too sterile. We're missing this human being in front of us. And so he was trying to define what suffering is. And a lot of the compassion literature calls back to Dr. Cassell's writing on suffering and the nature of suffering. So his definition evolved over time. But where it came to, and the one that I use when I talk, is it's anything that threatens your intactness as a whole person. And so that acknowledges that we are multifaceted human beings. You can have spiritual suffering, you can have physical suffering. When my kids are sick, that can threaten my intactness as a whole person. And again, because our identities, like as professionals and people, like they're deeply intertwined. When our professional identities are threatened, that can be a source of suffering because it threatens our intactness as like whole people. And so, yeah, I think for like any individual clinician, training can be a source of suffering because we're not able to be whole people. We have to be just a single thing. Moral distress, as you mentioned, the notion that like I know what the right thing is to do for my patient, but I'm not able to do it. The system is preventing me from doing it for some reason.
Right.
Grief, I think, is a source of suffering. I think the degradation of provider autonomy is a source of suffering. It's a difference of expectation and reality, right? Like when we expected or lived through a certain way of doing things, and then that is stripped away, that can threaten our intactness. For pediatricians, I think truly the fact that gun violence is the leading source of death for children is a source of suffering. We desire for there to be a world where children are safe from that and feel distress about our inability to, for some reason, move the needle on that. And, I think I wrote in that piece, I may have pointed at this, but I have a family member who's a general pediatrician, and she worked for, a sort of a private firm for a while and would recommend vaccines. And she lived in an area of the country where that was not popular. And so then after the visit where she's offering and suggesting evidence-based practice, families would go online and kind of trash her and give her low ratings. And then the company she works for will use that as a reason to cut her pay, and it never actually happened, but there was like this threat. That's a source of suffering, when you are offering the right thing and your livelihood is threatened because of it. And I worry for pediatricians, what we're trying to figure out right now is how do we use our voice and our collective wisdom to helpfully navigate and advocate for the right thing for children, like in this moment in time.
Yeah. There was also, the time when a lot of our OB colleagues were suffering,
Yes.
With a lot of political things that were going on. Yeah. How would organizational grief, you think, manifest, and how would it impact, mental health among healthcare workers, their morale, or what signs would you see?
I think it just manifests as like sort of stress, distress, and trauma. And you can feel it, like as a palliative care clinician, part of what we do is we check on people. And now as a wellness officer, we're checking on people all the time. And I think it bubbles up. You hear it. And I think sometimes we know, right? Like we know if a coworker has died, that's a source of suffering and grief for those people. And so our responsibility is to respond, is to notice, acknowledge, and respond compassionately, because unattended grief, unattended suffering makes it worse. And does lead to low morale. It does lead to feeling like disconnected from the organization, as opposed to when leaders show up and even just acknowledge, like, oh, your coworker died. We're thinking of you. Just the acknowledgement goes so far because it acknowledges our shared humanity. It doesn't have to be a big, strong display. It can be a small thing. It can be a card. It can be somebody walking over, and just sort of saying, how are you guys? Or, policies that allow people to easily take that day to go to their colleague's funeral. So it's not like a big, hard thing, to get the PTO. It's just like, yes, go, bereavement policies. At the national level, I think the state of bereavement policies is pretty dismal. It implies that you're supposed to grieve for 3 days no matter who died, and that's it. Like, it's not realistic.
Yeah.
Everybody will experience the death of a loved one at some point. And when it's a spouse or it's a child, like that's not nearly sufficient. So just making things easy too, right? To access like resources and the making it harder, I think, can make grief worse.
Yeah. Can you think of a time when you saw that within your organization? For me, I think COVID and post-COVID, and I saw a deep depression amongst all the nurses that I was working with and all the physicians. It was just a low morale. Like people wanted to quit their jobs and they wanted to go, and we were going through this pandemic, So I remember seeing that, and I see a little bit of it now. Too, with the political climate changing, I see a little bit of depression amongst people now with the vaccines, and people are feeling kind of dismay. Do you remember a time when you saw it?
Oh, I think COVID is the best example. We all lived through it together. There was so much fear and so much uncertainty. It was disintegrating, which is like sort of the definition of trauma. It's not necessarily the thing that happens, but how the response to the thing that happens.
Yeah.
And it was a collective trauma. And, there's this researcher named Ace Simpson who is really interested in organizational compassion in healthcare. And I had the opportunity to hear him speak a couple years ago. And he put up his research had been all from the perspective of the actor, right? Like, so did you notice that somebody was suffering and did you make an empathic connection? Did you respond? And he appreciated that during COVID in the NHS, like every day at 7:00, people go outside and clap for the caregivers. And the caregivers said, stop clapping. You need to pay us a living wage. We need to be able to eat. We need to be able to pay our rent. And his point was like, not every attempt at compassion is experienced as compassion. And so like the language that we use in our team and in our research is like competent compassion is highly personalized and meets the needs of the sufferer, as opposed to incompetent compassion where like an attempt falls flat. So like during COVID, there were all these stories in the media about like places where patients are just dying. And this was luckily not what really happened in pediatrics. We experienced it a bit differently, but on the adult side, right? Death upon death upon death. There's no PPE. And it's like, here's your pizza, here's your muffins. And the response was, I don't need that. I need PPE. I need to sleep. We need adequate staffing to meet this crisis. That's what competent compassion looks like in the moment. And so I think organizations that were able to hear the front line's needs and respond compassionately and competently were the ones that weathered it in a more healthy way.
Yeah. Which brings me to ask you, because we haven't really defined it, what is organizational compassion? I know that's something that's your expertise.
Yeah. So in the management space, it's sort of defined as like cultivating conditions in which when someone brings normal human suffering, like grief, into the workplace, someone else notices and responds. So it's really meant to be kind of like on the person-to-person level. In healthcare, the way that we have defined it, because working in healthcare is different and has inherent sources of suffering. Caring for dying children is an inherent source of suffering. I'm prepared for it, and I know what I signed up for, but it is. And then there's all these avoidable sources of suffering that the workplace can layer on. And that's what needs to be mitigated at the system level. So we define it as like systematic, continuous, and proactive identification, prevention, and alleviation of sources of workplace suffering. Prevention call out is purposeful and new to say, like, if you know that there is a recurrent source of distress for the people that work for you, it's not enough just to respond. You also need to prevent that over time. It's your responsibility as a leader.
And how do you advise leaders manifest that? What are some of the things that you have done? I'm very curious. Yeah.
So when I talk about it at the level of the individual, the team, and the organization.
Okay.
And so much of the literature in this space, in the burnout space, and the well-being space, really focuses on individual interventions. And those are important. We have to learn how to boundary ourselves and take care of ourselves and practice self-compassion, practice mindfulness. That's all true. That will only get us so far if the system itself is not designed with our needs in mind too, and to take care of us over time, right? At the level of the team, I think ongoing debriefs are really important. Cultivating trust within the team, which can include storytelling, which can be formal or informal. Shorts rounds is a beautiful way to do this. That vulnerable storytelling. I think it works because when you hear a good story, your brain releases oxytocin and you feel trust and you feel safe and you feel love for that person. And so I think that vulnerable storytelling with good listening is a really beautiful way for teams to start to like cultivate, maybe through debriefings, through facilitated, moderated debriefings, just supporting one another. Like if you're a team leader, thinking about how you structure the workflows so that people can be flexible and have autonomy is really important. Or like in our palliative care team, we sit down monthly, we run the list of patients who have died in the past month. We talk about them, we remember them. We talk about what we did well. And if someone's having a difficult day, we have the ability to flex and cover for them. Like maybe today you shouldn't go to the PICU, I'll cover that, and you could do the outpatients or whatever, right? So flexibility built into workload sharing. At the level of the organization, like our C-suite, our CEO, COO, Chief Nursing Officer, Chief HR Officer, they all became part of the Schwartz Center Healing Healthcare Initiative pilot. So our organizational leaders were trained in trauma-informed organizing. And that was a whole curriculum that Schwartz Center put them through that talked about priority, like indicator areas, like mental health and well-being, physical and psychological safety, trust and trustworthiness. And so our leaders prioritized physical and psychological safety and mental health and well-being. And the wellness office partly grew out of that work. So our tip-top leaders have had training in this and think about this when they're thinking about how they take care of the workforce. So then the Office of Wellness can carry that work forward. And we embed the notion of organizational compassion and what we call healing architecture into our strategy and into our key driver diagram as a wellness domain. And so that can look like physical spaces. How is the physical space in which we work designed for formal and informal decompression? How is it designed so that people can talk to each other? Is it designed in the way that's healing in the same way that the patient spaces are designed? Often, we'll focus really carefully on the patient room and the patient-facing areas, but the clinician-facing areas are not painted with healing colors. They're not really designed for our wellness. They could be, though, and it's not that much more money to do so. And it helps us, decompress and take care of ourselves in time. We think about stress first aid. Stress first aid is psychological first aid. It's been adapted by the Schwartz Center for Use in Healthcare, spreading those techniques and not just teaching them once, but really embedding them in different units so it becomes part of culture, that you're constantly checking on one another. And then if someone is stressed, you know how to respond in a way that's helpful. So that's like organizational compassion in action. So that's all these, we're doing lots of different things to try to get at it in different ways.
Yeah, that's awesome. Yeah. And I think trauma training, that's really good that the leaders were doing the trauma training, so they can incorporate it, and just having more trauma-informed care for the providers too, I think, because they need it. Yeah.
Yes. Yeah.
What are the little things, like small, impactful, like small things that, healthcare teams can do? Because I know these are big initiatives and not every organization, has the infrastructure to implement them, although they're amazing and I wish everybody could do it. I want to know what are some small.
Yeah, if teams can just pause for 30 minutes and talk to one another and have lunch and get to know each other, then when someone isn't doing well, you're much more likely to notice. And you're likely to have cultivated relationships that when you check on them, they'll allow themselves to be checked on. When I was really burned out, there were two people who noticed and said, they could tell by my face, by how I was interacting, that I was not okay. They were both physicians. One's a pulmonologist, one's an anesthesiologist. So neither of them was within my team. And they said, "How are you? You're not yourself." And I said, "No, I'm fine." I waved them off, right? That's what we do. I'm fine. I didn't want to talk about it, but they didn't take no for an answer. They didn't accept the wave off. They double clicked. So they both independently came to my office within a couple of days, shut the door, sat down and said, "Talk to me and tell me what's going on." Their knowledge of me was formed in time through multiple small interactions, right? And my trust in them to tell them the truth was also earned in time.
Right.
So it's those small ways, right? It's gratitude and recognition. It's thanking the people around you. It's just caring about the people around you and showing them that you care about them and not assuming that they know just because you're showing up and doing the work every day.
Yeah.
So it's just taking that little bit extra intentional act of kindness for the people around you. And one of the changes that I've made just over the past couple of months, I try to every day send somebody an e-card, somebody on my team or somebody from around children's, just to say, "Hey, I appreciate you so much." Receiving that I get them all the time. And I'm like, "Oh my God, thank you for taking 5 seconds to do this. It means so much." But that's how trust becomes healing architecture in organizations. It doesn't have to be big programs. In our Schwartz rounds last week, one of the nurses who was a panelist said, "Programs don't heal people, people heal people." And so it doesn't take a lot of energy or a lot of time to cultivate those relationships. It's just you just have to get over the inertia and do it.
Did that feel too confrontational when you were being called into the office and being told, something's wrong with you? I'm just curious.
They were not in a power valence that would have made me nervous, right? I wasn't in trouble because I didn't report to either of these people.
Right.
And even then, had it been the anesthesiologist in chief, I knew him to be a caring, compassionate individual. So even if he had been the one to notice and call me in, because of how I had interacted with him in time, because this was a couple of years ago, I would have felt very safe because he had earned my trust. But no, it didn't feel confrontational. I was grateful. I knew I needed help. I didn't know
Yeah.
how to get help. Yeah. So no, it didn't. It felt so compassionate.
Yeah, it did feel. What would be the way, like when you approach your colleagues or somebody who you know? Because I know for some people it can feel like when somebody's coming to you and say, "Hey, something's wrong with you," it almost
Mhm.
feels like, you said it's our whole identity, being a physician, being a nurse, and then when something's wrong with that identity and you are pointing it out, like then that feels kind of like it's kind of
Yeah,
injuring
it
my
feels
intactness.
pejorative. It can feel accusatory. And I think too, when you're burned out, part of the burnout syndrome is cynicism. And so
Yeah,
your trust of the person in front of you is low just
yeah,
because you're burned out. And that's what
yeah,
makes it really hard. I worry that people who are burned out actually have the hardest time accessing help or receiving and experiencing authentic compassion
yeah,
because of the way the syndrome works. So what's recommended, like in stress first aid, for example, is to make sure, like what they did. They came to my office. It was a quiet time. They sat down. So they set the stage to have a conversation that felt safe. It wasn't in a hallway. It wasn't around other people. And they said, I've noticed. Like I've noticed that you're not yourself. I can tell by these ways. And they gave me specific examples of how my behavior was different.
yeah,
Um, and, like with my coach, we talk a lot about like observation and impact, right? Like, and then requests, like, I've observed this and it made me feel sad. It made me feel worried about you, right?
yeah.
Will you tell me how you're doing? And it won't work 100% of the time. There will be people who simply either don't want to talk about it with you, and that's okay. I think the attempt is what matters, or they don't want to talk about it at work. They have their other ways of like working through that in their own personal lives that are
Yeah.
healthy. That's okay too. Um, as coworkers, all we can do is offer and try, and sort of gently push back if we get waved off like they did. It's
Yeah.
like, no, actually, honey, like, and it made all the difference for me that they did that they double clicked and didn't just take no.
Yeah. Sometimes you just want somebody to ask too. You're just waiting for that one person to ask. I totally get that. And sometimes you're so guarded. But in your work that you're doing, what advice would you give to any leaders or somebody who is leading an organization listening? Because I remember a time in our hospital, and usually that happens after winters when
Mhm.
everybody's like in the dumps of depression, especially on the pediatric unit too, because everybody's so
Yes.
busy. And, I felt like there was a dismay that leaders didn't know how to fix it. They're like, the whole workforce is down. We just don't know how to break through. And
Mhm.
what would advice would you give to leaders to show this sort of compassion, and how would they implement it?
Well, looking from our research, we asked, we did qualitative interviews with 22 clinicians asking about suffering, compassion, and how compassion shows up. When leaders are physically present,
Yeah.
especially after something difficult has happened, it goes a long way. You don't have to fix the problem. All they want to do is see your face.
Yeah.
When they really believe that you care about them as human beings, that goes a long way. And again, it doesn't have to be complicated or expensive.
Yeah.
It's just showing them that you care. The way that can be operationalized is, do you listen to their needs and do you actually respond? Because there can be a lot in the way of making disruptive changes that are needed to help people. But when we're able to and demonstrate that we use the feedback for change, you have to also like take the step of feeding back, like, you told us this and we did this. Because people do not always make that connection on their own. So a lot of this is just in like really authentic and genuine
Yeah.
direct communication and repetitive communication. Um, but if you're willing to make a change for the better based on what they tell you, then that is experienced as compassion too.
Yeah. And sometimes, they don't have solutions. So when you were doing your research, did it seem like people wanted more solutions, or do you think based on the work that you've done, because sometimes there are no solutions, and I don't know if it helps as a leader just to be there in that compassionate space, even if you don't have a
Yes.
solution. It does.
Yes.
Okay.
Yeah, it does. Absolutely, it does. We did a COVID grief event last year, the 4th anniversary of COVID, and it was fully virtual. Um, we did sort of like a mini shorts rounds. We had some panelists and just kind of reflecting on what had happened during COVID. The CEO joined. I didn't ask him specifically to join. He saw that it was happening, and just his presence signals this is a priority. Your grief is a priority, which I thought was really lovely. And he was participating in the chat too. But what I took from that and what I wrote down on my whiteboard, like my source of truth, people just want to feel human. The workplace can feel really dehumanizing when we're treating people as workers instead of full human beings. And acknowledging that we're human beings doesn't take a lot. Merely being present and merely acknowledging distress and showing authentic caring goes a long way.
Yeah. When there is grief from things that are going around in the world, like you talked about gun violence, right now there's a lot about vaccination, especially in the world of pediatrics. There's some grief about the rise of diseases that were eliminated by vaccination. Do you think leaders should show compassion there? It's a tough question, because I know they may feel a certain way about it, and not everybody feels the same way about it. So,
yeah, this has been a gnarly problem as a wellness officer. What does an organization respond to?
Yeah.
And so what I think that we should do and what we've been talking about is just creating like ongoing monthly or every other month spaces for people to sort of come together and acknowledge our collective stress, distress, trauma, suffering, but also joy, hope, gratitude, optimism.
Right.
At the same time, with a leader present for like to come together for a moment of silence to be interpreted in whatever way any individual wants to, so that it doesn't feel reactive. Oh, we reacted to this war, but not that war. We reacted to this shooting, but not that shooting.
Yeah.
There's always something in our workforce that is heavy. There are also things that are bright and beautiful and affirming. It doesn't have to be complicated for us to come together and hold a minute of silence, maybe with some music, maybe with the poem, for 5 minutes, virtually even, since Cincinnati Children's, for example, has like 75 different sites of care. Everyone can't be in one place at one time.
Sure.
But it's just the acknowledgement, right? And then if it's a regular routine thing, it becomes, again, like part of the fabric, part of the architecture of the organization. Instead of feeling reactive, it's proactive.
Yeah. And I agree, sometimes just the acknowledgement goes a long way, and it doesn't have to be named, but just the lack of acknowledgement can create more suffering amongst the people who are working in an organization.
Yeah, and I mean, you're a pediatrician, I'm a pediatrician. We have chaplains. Like this is really their space.
Yeah.
And so our program has a very tight connection to our spiritual care staff because we have grief workers who are caring for the grief in our parents and families when patients die. They also lean in and provide grief care for staff when coworkers die or patients die or something sort of salient happens.
Yeah.
So we have this like wellspring of compassionate people that this is part of their job.
Yes.
So it's fully integrated into all of our clinical sites of care. How then do we also integrate it into our research space or into our non-clinical space so that everybody feels like when they need it, they have access to those tools?
Yeah. And do you think debriefings help? Because I know there's some data about like it does, there's some people who say it helps in the moment. Some people say it can be too much, but yeah.
I think what you need is a toolbox of resources because one thing isn't right for everyone. And an intervention might be right for some people at one moment and right for other people at another moment. And so we think of this as sort of like critical incident recovery. We have a robust peer-to-peer program. We have a fantastic employee assistance program. We have spiritual care, but we have not historically had a way to like activate that and ensure that it cascades and rolls out in a way that's reliable so that everyone who needs help can receive it when they need it in the right way.
Yeah.
And that's one of the things that our office, the Office of Wellness, is working on is like, how do we ensure that like, okay, thing happens, there's a one click that just cascades all of it. And then it's all like unrolling over time for everybody who needs it whenever they need it.
Yeah. Yeah. I think that's the tough piece of it. Yeah. Because especially when you're working in a bigger organization.
Mm-hmm.
You mentioned stress first aid a few times. I know what it is. I was just going to say, if you want to mention it for anybody who's listening who doesn't know and is interested in how you've applied it to. Yeah.
So stress first aid is psychological first aid. It's a model that was developed by Patricia Watson as part of the Department of Defense for EMTs, active duty service members, people who are experiencing stress, distress, and trauma as part of their job. As a way of noticing in the moment. It's first aid. It's not like trauma-informed care. It's not therapy. It's just how do you give and receive help with your colleagues in the moment. And so it teaches a stress continuum that goes from green to yellow to orange to red. So there's shared language. And then it teaches these different techniques that you can use. The first one is check, and then the second is sort of like coordinate. And it's like, how do you pull people to the right resources in the moment? How do you understand like what it is that they need and then get that to them to provide first aid, right? Like it's like, again, it's not a trauma bay.
Yeah.
It's just first aid in the moment. And over time, the goal is that these techniques, the checking and the noticing, and then the bringing people to the right resources just becomes part of your way of doing things on your team.
And it's more like a response and not a preventative thing, right? Like stress festered, you would say like more of a response. Yeah.
Yeah, it's for response because stress is inherent to healthcare. Even if we perfect the EMR and we right size the work and everybody's going home at the end of the day with all of their work done at the right time, the work itself is stressful.
Yeah.
And we have to have ways of acknowledging and taking care of each other, taking care of ourselves too. So it also just builds self-awareness. So you know where you are on the stress continuum and what you might need to help you get back to a place where you feel like you're really thriving.
And are you applying it currently? Like, do you have like a trauma response team or?
Well, we have a peer support team, peer to peer, stress first aid. So yeah, we've taught hundreds of people at Cincinnati Children's these techniques, but we're also piloting it really purposefully in the ED and in the NICU this year to try to understand with implementation science support from an implementation scientist, how do you enculturate these practices? So it's not just like a one-off educational thing. Oh yeah, I heard about that. And I have, like, I'll show you my badge reel. I have like my stress first aid badge reel that reminds me how to do things correctly. No, it's actually really a part of like your way of behaving to the people around you.
Yeah, just get it into the culture. What words of encouragement, advice would you have for people who, individuals, I would say, who are maybe going through suffering at any point related to their careers or whatever is going on in the world? Some words of encouragement based on your experiences and what you've been doing.
We are so hard on ourselves. Really highly productive, highly achieving people find their way into medicine. And we can be really, really hard on ourselves. Part of what I felt was missing from the literature about burnout and why I wanted to write that piece was it felt terrible to not show up as my best self. And I was telling myself a story of insufficiency, about my insufficiency. It just makes everything worse. And so self-compassion is really, really important. Talking to yourself like you would talk to a friend.
Yeah.
I think any source of grief or suffering or stress can feel really isolating, and we can have a tendency to self-protect and sort of like become a spore and like keep ourselves away from other people. For me, that's the wrong thing to do. I have to actively fight my instinct to go be by myself and just like sort of work through it on myself. I have to carve out time with friends or, I go to therapy. I started therapy after a difficult patient safety review sort of incident here. I just thought, man, I need more tools if I'm going to survive in this place. And was lucky to have a relationship with a therapist before COVID hit and everything got terrible.
Yeah.
And I don't go to therapy often now. Like right now I'm doing pretty well, but I know he's there if I need him. Not being afraid to access tools that are available to you, not being afraid to be vulnerable and being honest with people you trust about how you're doing so that they can help take care of you. We want to take care of each other and fighting that urge to self-isolate while trying to be compassionate and tell yourself a different story. It's practice though. I think there's this idea that, I'm going to get there and I'm going to be this like Zen monk that has all of this down. No, it's a practice. I am constantly fighting these things in my own life. And for me, what has been helpful is I meditate every morning. I'm not a good meditator.
Yeah.
I am terrible. But it's a practice. Every morning, I sit down and I do a guided meditation for 5 minutes or 10 minutes.
Yeah.
And that has created like a container for me to hold stress and has brought down, I'm not reactive all the time when things are coming at me. I can stay cooler and calmer and work through things in a way that's healthy.
Yeah. I think one of my last questions, but how do you think about grief and suffering today? Has it changed from like 2 years ago or 3 years ago when you were in burnout? Are you thinking about it differently?
I'm just so aware of it on the organizational level now because of my vantage point, as a wellness leader, and frustrated with the state of the literature that it's not something that's discussed or talked about or researched much because I know it's real. I know I can feel it. I am grateful to be in an organization that enables me to respond and to talk about things like this.
Yeah.
Because they know they're real. I just think of it differently. And I'm grateful, so grateful for our spiritual care staff and our chaplains who see this space as part of their responsibility and are trained to respond and show up for all of us just as part of their job, So that's how it's changed for me. Like I thought about it in the team and I thought about it like as an individual, but now like from this vantage point, I go, oh, this is actually like a source of suffering at the level of the organization that it kind of rises and falls depending on what's going on. And we just need to be prepared to acknowledge it, to give language to it, and then to respond.
Yeah. Awesome. I think we're going towards our end. Is there anything that you wanted to say and you haven't gotten a chance today to say yet?
What are you enjoying most about this podcast?
Oh, well, I think just meeting different people and just hearing all the wonderful things they're doing. I think I love that. Because, when we started it, we were thinking about, more people are going to watch it. And, it takes time. The outreach takes time. But every time I sit to record, I meet someone so wonderful and I hear all the wonderful things they're doing. And I think that's what keeps me going. Yeah.
Oh, good. What brings you joy?
Me, I think mostly because I work in pediatrics, the relationships with the families. So when I go and I'm able to help somebody feel better and, parents come really distressed in the hospital. So when they're going home, that relief on their face or just that one word of reassurance that you tell them and that gives them relief, I think, yes. But yes, there are some very hard days in pediatrics, which is what has provoked me to do this work. And I've had some really hard experiences too. So I think it has made me stronger though. And just helping others and talking about this stuff also helps us thrive. I think maybe you too, just helping others. Yeah. So that's how I'm kind of coping with the hard days. Yeah.
Yeah. We'll get through them together. But it takes community and community can be a source of hope in really important ways.
Yeah. Awesome. We have a tradition on this podcast that we end it with a poem. So if you'll stay with me for that.
Yeah. I love that.
As we close today's conversation on organizational grief, we're left with the question, how do we hold space for suffering, our own, our colleagues, and the world's without becoming numb to it? And the poem that I'm going to read is Worcestershire's What They Did Yesterday Afternoon. It just speaks to the collective pain, the grief that lingers in the air and the news in our workplaces. But perhaps in naming it, in witnessing it together, we take the first step towards healing. So, they set my aunt's house on fire. I cried the way women on TV do, folding at the middle. I called the boy who used to love me, tried to okay my voice. I said hello. He said, Warson, what's wrong? What's happened? I've been praying, and these are what my prayers look like. Dear God, I come from 2 countries. One is thirsty, the other is on fire. Both need water. Later that night, I held an atlas in my lap, ran my fingers across the whole world, and whispered, Where does it hurt? It answered, Everywhere, 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 everywhere. Thank you so much, Rachel, for doing this with us today.
Thank you.